Hi, I'm Brad Power, and this is the Cancer Patient Lab, and we're honored today to have Michael Liss with us. Dr. Liss is at UC San Diego. He was referred to us by co-founder Brian McCluskey, and he's going to be talking about the gut microbiome and how it impacts cancer, prostate cancer specifically, but in general for other cancers and sort of what's at the cutting edge of the connection with the microbiome. Just a few housekeeping things before we get started. First of all, this is for information purposes only. This is not medical advice. We try to arm patients with information that they can take to their medical team. Second, this will be made public. Everything you say can and will be used against you. uh, and so if you're concerned about that, then you can hide your image, you can change your name, and don't say anything. And then finally, we are a patient-led, all volunteer nonprofit, and we would welcome donations, which you can do through our website and the donate button. And with that, I'll turn it over to Dr. Liss.
Great, thanks everyone from across the country. Let me share my slide here. Let's see if we can make that full screen. Okay, everybody see that okay?
Yep.
Perfect. Wonderful. All right, so I'll talk about the gut microbiome. You probably heard of a lot about this in the comings and goings and in the news. I'm a professor at UCSD, and I'm the director of clinical trials for the Center of Microbiome Innovation. I do have a company focused on this particular topic, but I won't go into the very specifics. At the end, I'll make a couple comments about it. This is kind of the agenda. What's the microbiome? A little bit about prostate cancer, algorithms, and how we kind of may be able to use this information. And then we'll get into the questions. So this is kind of how we think about microbes. This is a museum actually in Amsterdam. Of course, somebody like me would go to something like this. That's why it exists. It's called Micropia. And it just kind of takes us all the way back to the 1800s when we started looking at bacteria, and we actually had to pull them out on these little plates, right? And you had to have very specific plates to grow certain bacteria. And so we were a little bit limited. But we know that a lot of the microbes that occur in our gut, and this is kind of one of these virtual things you stand in front of and you go, whoa, where's all the bacteria in your body? Well, most of it's in the gut. That's where a lot of the action happens. So a lot of these bacteria are there. And they're not all bad. So I usually show this slide because these particular birds clean the teeth of alligators, and they're not going to eat this bird because it's basically its toothbrush, right? And it prevents disease and things like that. So we think something is maybe horrible when we see these names, right? But it actually may be beneficial. And I think that's where the microbiome and all these microbes with fancy names get a little bit confusing when we start talking about them. But not all of them are bad. And so when we say biome, we have to go back to, fourth grade biology. And that's where they get, microbes and living in different environments. So if you live in the Mississippi River Valley, you're going to have different bacteria or plants and things like that than you would if you're living on the mountain coast. And so this concept goes throughout our body, like what is in our colon is not the same as our skin. And we could use those differences. Now that we can start comparing diseases. So even within the Sierra Nevada mountains, if I put in, or take out a wolf, well, that changes the whole ecosystem. And that's how we start thinking about the microbiome, is that it's not just one bacteria, they're all kind of communicating. And so just a little primer on, well, what do we look at when we talk about the microbiome? And a lot of it is diversity, or how many. So there's alpha diversity, meaning how many kinds of microbes are there, and beta diversity, which is what are the relationships with these particular bacteria. And so when you see some of the papers come out, this is how we compare different things. And I say this, in the next slide will make a little more sense, but if we have, let's say, samples from different patients, and we want to compare them, well, we take sample A, we count, okay, we got 3 greens, 2 purples, and 2 browns, okay? And that's that. And we kind of set up a whole table like this. And now we set it on 3 different axes to see, okay, where in 3 dimensions does this person lie? And we can see that B and D are more closely related than, B and A. And so that's how we can do some of these comparisons of different microbes. Um, and so some of these slides I was just presenting at a urology group meeting in Idaho just the other day. So I wanted to use some of these new slides that I used in that meeting. And so when we look at this is basically the Human Microbiome Project. So this came out quite a while ago using 4,000 samples, and that's how we grouped different uh, you know organ sites essentially. And that's just that previous slide is exactly how we did that. And so when we talk about the microbiome, there is different sites, right? So if we're talking about prostate cancer, at the very bottom of this slide, the genitourinary microbiome that we can get from directly in the tissue or in the urine is very different than what we're talking about in the gut. So the gut can be manipulated by diet and things like that, whereas the urinary stuff may be manipulated in a different way. And so when we move to prostate cancer, we know it's a very common disease. And when I first started thinking about this particular, I had a lot of microbiology background and I was looking for a way to kind of marry these things because I felt like they were related. And I started looking at inflammatory bowel disease. And there was some papers that had come out saying that there's this link between gut inflammation and prostate cancer. So I said, because it doesn't make sense, well, how does bacteria in your gut somehow relate to a prostate that they're not connected? They're close to each other, but right, there's no connection between the colon and the prostate. And so this inflammatory aspect piqued my attention to this. And then basically, we said, okay, there's a healthy microbiome, a cancerous microbiome, and can this start impacting what we're looking at? And so this was just a diagram I show. Let me try to minimize this. And that showing the relation here, we have the colon, there's the prostate, and the bladder through and how we void out the urethra. So there's different concepts of things going on here. So within the prostate, there can be various organisms. If they can cause DNA damage, can they make certain substances that are within the prostate, or is it a chicken or the egg situation where a cancer can form, and then maybe the microbes that can live in that environment are different than if there wasn't a cancer there. So can we use that as a biosensor? And then the other aspect in the gut is as we get older, men can have urinary tract infections or inflammation or something like that. And those bacteria usually communicate from the rectum over to the the urinary system. And so things that are in the uh, colon can directly impact the prostate, but they also can make microbes and cause generic inflammation and things like that we want to watch for. And so we first published on this topic back in 2017, and I basically used patients that had cancer versus not, and I used their gut microbiome, and we showed that there were some differences. And if you kind of make a line diagonally through this, you can see a lot more orange on one side and more blue on the left side. And so that kind of said, okay, some of these patients are grouping around, so they have similar bacteria. And then I looked at their function. Okay, what are these particular bacteria doing? And we came up with B vitamins, which are folate and biotin. Now, it's not something that you take. These are biosynthesis mechanisms. So it's essentially, for folate, it was biosynthesis. So the bacteria that actually make folate for you. So we want to feed those types of bacteria. You don't necessarily want to take folate. You just want to feed the bacteria that can make it for you. And then biotin metabolism was, okay, do increase things that have biotin in it, not necessarily the pills themselves, but the dietary components so the bacteria can break down the biotin themselves. And then the people were more common on the cancer side were these starches and sucrose. So a lot of sugar, carbohydrates, common things that we think of, okay, we don't have to eliminate, but maybe take a look at your diet and see, well, okay, what are the sugary stuff I'm eating? How much carbs am I eating? Not that you have to make drastic, but even small changes in diet can change these bacterial mechanisms. So kind of a similar concept that I showed on the last slide, but what I wanted to say was we're starting to understand on the right here the interaction with the immune system. So now, what is the real function of all these bacteria in our gut? Well, it can do stuff for us. It can make vitamins, it can digest our food, but then it also has a function in that it goes in to our androgen presenter, our antigen presenting cells that are in our colon. It takes these bacteria and shows it to our immune system, and it trains it in a certain way. So we're just kind of touching the surface on how exactly is this done, and can we manipulate that system to show it certain bacteria and train our immune system in certain ways. And so I think that's where a lot of this research currently is heading. Sorry, so I'll go ahead here. So can we take, this is a complex thing, but what I wanted to show was that we can take this down all these different avenues and show, okay, we take a bacteria and then we show what types of bacteria are there. And then we have to use all these different steps to select the certain bacteria that are there, to confirm which bacteria are present there, remove contaminants. But then we can start using, and this pathway down here in the lower left would be, okay, what are the bacteria that are good? What are the bacteria bad? And now with AI, we can develop cohorts and say, okay, if this particular bacteria is present or absent, yes or no? And two, is this bacteria abundant? What abundant level is it at? Is it 50%? Is it 1%? And so all those yeses and nos can be put in an algorithm to start figuring out, on the right side, can we develop prediction models for disease types? And so this was the paper that this isn't published yet, so hopefully nobody um, posts it. A lot of the stuff I know it's recorded, but I did want to show that, we have some biologic gradients here showing cancer, and based on our scores over time, can it get, the likelihood or risk of cancer in the future can go up. So we can actually build biomarkers based on some of these bacterial groups. And over time, we compared predicted events versus probability, and the gray is like kind of your usual risk, clinical risk factors, and we want to be close to that. And that just the microbiome alone can actually mimic what we can find clinically. And then over time, these graphs on the bottom show that if you have a poor microbiome score, that you may be at increased risks for certain cancers. And this is for prostate specifically. But can we manipulate it? Could it be modifiable? And so this is a study of inflammatory bowel disease. And so the teal and yellow groups are people with inflammatory bowel disease, and they're going to get randomized to getting donor stool. So this donor will give to the teal group, and you can see over time that the teal group then lowered their cancer score. So just by changing their microbiome, you can actually manipulate these scores. So I'll skip through some of these so we can get through. So here, I'll show you how complex some of these things are. So this is causal mechanisms with genotoxins, right? So we're looking at, are bacteria making certain, and this one just got published. I know these things are complex, but what we're showing here is at the bottom right, when we're using colibactin, which is a genotoxin, with hormones, that when you combine the two, they can cause a lot of DNA damage. So these are types of bacteria that maybe we want to find, and in the future, research to try to get rid of these types. I think I have a data set here. So, all right. So, what are different ways we can use particular microbes? So, one, vaccines are coming out. There are ways that you can use, and when I say microbiome, that could include viruses and other things like that. So you can use vaccines to inject into the prostate or into a local site that could increase the body's awareness of certain peptides that are carried by microbes that can expose right to that immune system that we're talking about. So that's one way that you can use the microbiome. Fecal transplant. Now I just showed you that other group where they would show for inflammatory bowel disease. And this is a common question. Can we start using fecal transplants? So this is a donor. They collect their stool, they can make pills, give it to a certain person with cancer, and then what happens there? So the mechanism is what we're still trying to figure out. But there is some studies in immunotherapy specifically for kidney cancer, lung cancer, melanoma. They have shown that if you do this, that you can actually boost immunotherapy. One of my goals is to try and do that with prostate cancer because it's considered a non-immunogenic tumor. Can we increase it into a hot tumor or a immunogenic system where now there's microbial peptides or training our T cells in a certain way that then enhance that immunotherapy. So the top is the T cells and the bottom is the macrophages. So these are all things that enhance tumor killing. There's also metabolites that those microbes can produce that can go into potentially therapeutic intent. So this is kind of the future of microbiome as a therapeutic. And so can we identify the favorable microbes and the unfavorable microbes? And I think that, you know, some of these things I posted here are in published data about the types of bacteria. And I said some of those names we can't produce, like Ruminococcus, but some are Streptococcus, Provotella. And these aren't things that are, oh, I can go grab a probiotic and take it and have these particularly grow per se, or I can get rid of them with a certain antibiotic some way. So these are all being tested in various ways to, you know, because taking antibiotics has its own issues. So as we look down here, what are the different things we can do to help our immune system? And so fecal transplant is one, but just like in the early days of when we say transplant, right, getting a kidney or even blood transfusion, we have to figure out what is in that. There is parasites, there are viruses, there's COVID, there's HIV, there's multi-drug resistant organisms, and you're taking all these things and putting it in someone else. And there's a really great Netflix show that you can watch called Hack Your Health about this particular topic. And so, you know, there's other things that we don't fully understand about the microbes because they can even impact mood, depression, obesity, right? So is long-term FMT the answer? I say probably not. I think we can rationally develop certain probiotics for treatment, and I think that's the way things would probably go, just because the regulatory aspect of doing FMT is quite challenging. For prebiotics, I think this is a great way to use our diet to enhance, you know, fibers and things like that to enhance those bacteria to grow the ones that we want. And so, you know, I put a little note in here about Provotella, is that's the favorable one. So how do we increase that? You know, fermented foods, the count of bifidobacterium, so some types of probiotics can help. But getting a pre and then a post, like you have to do something, you test it, you do something, and then you got to retest it to know is it actually working or not. So it's a little challenging to go. I get a lot of phone calls, okay, which one should I take or not? And it really depends on where you're starting. You know, a farmer just doesn't go to the desert and lay down seeds. If you have a desert type of gut, well, we need to find cactuses and things that grow right in that particular environment rather than trying to plant corn in an area. Or how do we transfer that gut from desert to more fertile ground? So I think all these things are just starting to come out. Probiotics are a pretty common one that I get asked about. And again, it depends on bacterial CFU counts. It depends on how the pill was made. Does it get past your gastric acid or does it die there? And, you know, sometimes they can be costly. So things that we have to monitor, but I do think, you know, one of those is an option. Postbiotic means, can I just take what are we trying to get from those bacteria? A lot of times it's like butyrate or different types of fatty acids. Well, can I just take that and then skip the whole bacterial side of things? And that is an option for some things, but again, it depends on how stable it is. And does it get absorbed in the system? Because your bacteria do a really good job at kind of accessing their metabolites to the bloodstream rather than just taking it. And then this last bacterial consortium, kind of a rationally designed consortia. So as we study different types of cancers, can we figure out who's more at risk for certain bac or which bacteria are more important, and then just focus on those particular ones. So I think that's the future. Um, a lot of people, I threw this in here too because I get asked a lot about, well, how does the microbiome impact symptom control? And so this study was done on breast cancer, and I know there's some survivors here. And so they were looking at, and I can look at the very top, alpha diversity, which we talked about how many different bacteria are there. And then they used diarrhea and nausea and vomiting as GI side effects. And so the people who had more diverse bacteria um, had less diarrhea in the second one and less nausea and vomiting, right? So before we start a treatment, is there a way to diversify our bacteria? And same thing with the bottom one, alpha diversity composite for neoadjuvant, adjuvant. That's kind of how they broke it up. But pretty much, if you had a more diverse, you had different types of bacteria in your gut, you were kind of doing better on those GI symptoms. On the right side, we took dietary stuff. And remember, way in the beginning of this talk, I talked about carbohydrates and sugars. Same thing with GI side effects. If you're really high on the carbohydrates and sugars, then you may have more GI side effects for those particular. And this was the paper in the lower left-hand corner. So I think that, is kind of a universal finding. And so that was pretty much it from my standpoint. And I can start, hopefully I didn't go over too far. And I can go back to some of the slides, but hopefully it gives you an idea of what the microbiome is and how we're kind of studying it. I wish there was more like definitive, this is what you do. And I know that's what a lot of people are looking for, but I have to be very cautious about that because we don't really know. This is just the kind of the beginning of this topic and how we can particularly use it. So I'm happy to answer questions from people. I know people hopefully have been writing down some that I can talk about.
Yeah, we use the the raised hand feature, and I see Alan Morris is already there, and also the chat. So I'll pull things
Yeah.
moderate for you, Michael, from the
Yeah,
chat.
so I can read the chat
Oh,
ones. I can
okay.
read it. Yeah. So
Okay.
over-the-counter probiotics frequently contain lactobacillus. You recommend over-the-counter probiotics. So again, um, I think, if there's a way to know if they're working. So I'm going to say this about natural supplements. I have a PhD in translational science and I work on natural supplements, so I'm not against it by any means, but I think what the issue with the industry was is that if they're already selling it, then they don't have to do the research to prove anything's working, right? And so we have to design studies, which I'm doing, using natural products, probiotics, things like that, to test them before and after to see, okay, if this person takes it, they have really changed? So I do think that trying over-the-counter probiotics, but the things to look out for are the CFU counts, the different variety of bacteria that are in there, and then if they make it past the stomach acid. So do they have a delayed release capsule? That's super important. And then it's a bit of symptom control, right? And that I would say for that, are we using it for prevention or progression, to reduce progression? I can't recommend anything like that. Um, the Clostridium study with double checkpoint inhibitor in renal stone cancer. Is that a phase 2 study? Okay. So yeah, so that's the CBM, Clostridium butyricum. That's why I mentioned butyrate. That was a phase 2. That's out of City of Hope trial using a probiotic. So we're hoping more of those studies come. But again, it is a phase 2. Um, so we got to get that to phase 3. That's being planned for in SWOG, which is our Southwest Oncology Group NCTN trial. I think that was approved to move ahead. So I think we will be moving to a phase 3 study. So I'm really interested in that particular probiotic. Akkermansia, there's pluses and minuses on Akkermansia. With regards, I think it's universally thought to be okay enhanced for immunotherapy, but it's really tough.
Here, probiotic, before I forget.
The probiotic.
I think she might have been speaking to someone else.
Okay. So Akkermansia probiotic is actually quite difficult to make. And the ones that are out there have different variations on a theme here. So we have to try to get what the exact Akkermansia is and then what level do you want, right? Some people have Akkermansia go really up high when they have inflammation. So why is that? And so why is that elevated when I have inflammatory bowel disease, let's say? But those they're not benefiting necessarily from their immunotherapy. So we have to learn a little bit more about Akkermansia. I know people are jumping on it and companies are jumping on it, but I think the jury's still out a little bit. And when I was saying AI, it's not Akkermansia by itself. It's interacting with something else, right? So I don't think that there's going to be one probiotic with one thing in it. I mean, it was nice to see that Clostridium butyriticum study, but I do think it's going to be a conglomerate. So the next one is it true that probiotics are destroyed by acids in the stomach? Yes. Seed is a company that claims they have worked for this. Yes, I have looked at theirs. They'd have a double capsule probiotic. It is being studied. There is some pre-post data on seed, as well as VSL, which is the other probiotic. So those do get into the colon, which is nice to see, but you have to keep taking it. It will kind of go away within a week or two if you stop taking it. And seed is quite expensive, so not all of my patients can afford that per se. Now, just because that bacteria is in the pill, gets in the colon, is it having the intended effect that you want? If you're doing it for symptom control, you can definitely do that on your own. If you're trying to do it for something else, it's a lot more complicated. And that's why they don't, they have to be careful with claims, right? They're never going to say curing something or doing something like that. So I think that's our issue with natural products probiotics. How far are we commercially from taking stool sample of a cancer patient, then prescribing supplements, treatments to improve outcomes and tackle treatment side effects? So I said I wasn't going to talk too much about that, but that's exactly what I'm trying to do with with my company. So not necessarily taking stool from patients. So that's the FMT, fecal microbiota transplant. And a lot of the studies in Europe, because our FDA is very strict on what we can give. And the reason for that, it's not because there's like an anti-government issue going on here and they're restricting some type of treatment. It's because when we did do the C. difficile trials and they did do FMT, the problem was that a couple people had got really sick, septic. Some people had passed away. And why was that? Because they got transferred a multi-drug resistant organism and they got an infection in an immunocompromised person. So this is very sensitive stuff. And we were right to go, okay, hey, we should treat this like you're getting an organ transplant or getting a blood transfusion. We need to make sure it's really, really safe. So I think what we'll be using is as we go, I think starting with treatment side effects is a very reasonable one. Start in the beginning, allow you to take something and then treat and then test you again and kind of see your progress over time. So that's where I'm starting as well. And then as far as improving outcomes, we would need to start learning, taking that data, going, okay, in 6 months, are you on to the next treatment or are you in remission? Right. And then that feeds back to the loop. Okay, what bacteria were beneficial, which one were not? So as we start teaching that system, then we can start learning, okay, these are the bacteria that are really controlling this particular treatment outcome. Then we can start developing. So how far away are we? I think probably within the next 3 to 4 years, we could start developing trials on this particular thing. And so that's what I'm really focused on lately is trying to get to that point. Thoughts on Akkermansia? I kind of talked about that one. So I do think, as far as treatment outcomes, we don't quite know yet. A lot of the Akkermansia data is case control, right? These people did well and they seem to have Akkermansia there. Do we know how that works? Nope. Do we know why that person did it? Maybe they were exercising and healthy and had a great diet beforehand, right? And they were bound to do well. So in those case control studies where you're looking at benefit, people who did well and people who didn't do well, there's a lot of stuff in the background that you got to account for. And we have to be careful because these microbiome studies are not very big. So if you're comparing 30 people to 30 people, you're going to find stuff that maybe is not true. And so correlation between stomach issues and microbiome. Yeah, so that was the last one I showed. Not necessarily stomach issues. So if you already have, a GI issue going into a treatment, we know those who have IBD and or even GERD, if you have upper tract, if you're like getting esophageal cancer treatment and you already have GERD, you already have Barrett's esophagus, obviously that's kind of a difference. So each patient's a bit unique, and that's why I talked about the desert, biome versus the rainforest biome. So if you're starting out with the desert, well, how do we move you into a different category first? And then we can start manipulating things. And everyone's starting a different rung on that ladder. And so just taking stuff to me doesn't quite make a lot of sense. And there's a lot of companies out there that treat, that will definitely tr send you a microbial, gut microbiome thing. They also happen to sell a lot of the products that you can buy. And so those aren't quite tested for this particular situation. And so a lot of it is experimental, if you will, and to see if these things help. But I do think that the pre-post testing would probably be important. So what's my process for making recommendations for a patient? What tests do I do to match recommendations with a particular microbiome? And are there general recommendations? So, okay, I'll start with general recommendations because those are the easiest, and that's usually what we all get. And I've had family members go through the cancer journey as well, and you kind of just you get home and you're like, okay, what do I do? Like, I want to take some power here, control my situation. And then you just get, well, diet and exercise. You're like, well, like what diet? And some people go all the way from vegan to paleo to whatever. There's a lot of options. So I think that the thing here at UCSD we've been really focused on was the number of different vegetables you take per week. Okay, so we try to get to 30 different types of vegetables per week. You just make a list on your fridge, right? Celery, green beans, salad, spinach, whatever. You just list 30 of them down that are completely different. And that is the easiest way to not only get all your vitamins, you can increase your diversity of bacteria in your gut, and it doesn't have to be overwhelmingly a diet change. So that's where I think that's what I recommend basically is that you don't have to take any probiotics, you don't have to take any supplements. If you're just eating 30 different types of bacteria a week, or 30 different types of bacteria, 30 different types of plants, you're automatically going to increase your plant intake, and plant-based diets are coming on board here. But it's really hard for us to go, okay, you can't, if you like steak or you have an alcohol every once in a while or whatever, are those completely bad? Not necessarily. A lot of it also depends on what rung in the ladder you're on, right? If you're in the, really your microbiome is just needing a lot of help, okay, you're gonna have to be a little bit more strict on that than others. So you can do raw or cooked. It just depends. I think sometimes we leach a little bit out. They don't all have to be raw. But however way you can, I usually just say however you can get them down. However you can eat them. It should be enjoyable, right? We have to also live life and we want to make sure that we're enjoying it. So doing really restrictive diets, I just don't think are helpful because it changes our mood. And the other question about bifido strains. We don't know about all of the different types of bifidobacterium. Some of them are beneficial. Bifidobacterium came up from, infants, essentially. That's where it all kind of came from. So do we have infantile bacteria help us with cancer outcomes? Not necessarily. We do see trends that may help, and some bifidobacteria actually help other bacteria grow, right? So I think that's probably the more important piece, is that it's not necessarily the bifidobacterium doing something, but it is them interacting. So I'll go to take some of the hands up here. So I don't know who was up first, but how about Rob?
Thanks, Doctor. Um, with the work that I do with cancer coaching, we do something very, very similar to what you're working on now. Um, I actually do use AI to um, derive micronutrient deficiencies that may have initiated the DNA mutation of the cancers. And so we work backwards from that by developing a whole food, well balanced diet to help build the immune system, help with the gut microbiome, uh, natural prebiotic foods, probiotic foods, and then hydration, and the other is already, stress mitigation, physical activity. And what we've been seeing is if we're able to work with a client at least 3 to 4 weeks prior to them starting their treatment and be able to get the microbiome in a position where it's functioning properly, we're seeing similar results to what you're saying, where they manage treatment better. No side effects from chemo, less side effects, and whatnot. And it also allows us to target certain supplements, and a very small range of supplements that directly work with the gut microbiome and the DNA. So based on that information, it correlates greatly to what you're doing, along with hydration, as a key component to it. So I would love to actually talk to you.
Yeah, we'll have a separate thing, but we do use, we're on the same page because we use basically dietary questionnaires, right?
Mm-hmm,
And
mm-hmm,
so there's three components that I like to use. One is your diet, your current diet, where are you at, right?
yep,
Second is your baseline microbiome, and the third is your daily log. And it's as simple as I had a good gut day or I had a bad gut day, right?
mm-hmm,
And if you're
yeah,
lining up a lot of bad days together, we're doing something wrong.
mm-hmm,
And because everyone is so individual, right? And we want these, everybody wants these magic bullets. And
exactly.
this is the thing that everybody should be doing. And I just don't, when you do microbiome research, I can move you a little bit.
Mm-hmm,
Your microbiome is very resistant to change. And you have fluctuations through the year, right? In the summertime, you're eating more berries and
mm-hmm,
whatever. And in the wintertime, we're eating more potatoes or something. So there's little variations in it. But over the long term, they stay pretty consistent. And I can tell one person from the other person more
mm-hmm,
than this group of cancer patients and this group of cancer patients. It's
mm-hmm.
more aligned with yourself. So in
Yes.
order to make big changes in that, that's how I think we have to go forward with this, is treating what we call the N of one, you know.
Yeah, that's exactly
That's
what I
what
do.
the cancer
Yeah,
patient lab is doing, right? That's what you guys are doing,
exactly.
which is why I was excited to talk to this group. Um, okay, I'll talk to Alan. He had a question.
Hi, Dr. Liss.
Hi.
I do have multiple questions, but I'll just start with one. I joined you late. I believe you recommended 30 vegetables.
Yeah.
And I take it, therefore, do you agree with this statement? Therefore, you say that if you eat 30 vegetables, you do not need supplements. Is that correct?
Well, I mean, I think that your gut is extremely good at taking out what it wants. And so a lot of times we're eating supplements that are really high in stuff that we don't need. Um, so I either say you're making very expensive poop, or we could be doing some harm there. So why don't I increase the vegetable intake? And somebody asked about fruits, and not necessarily fruits, because fruits have a lot of sugar. So we can add fruits in there to flavor things and whatnot, but really it's the vegetables that are doing it. And so those different types of vegetables have zinc. They have these things in it. Now, I'm not saying that you still may need it. A lot of us have to take calcium supplements if you're on hormone therapy. A lot of us have to take, you have to watch your iron if you have low, right? So not all of it has to be from that. So this isn't combined with your team, right? It's like, yeah, you're going to be measuring these things. You have low blood counts. Well, I'm eating 30 vegetables. Yeah, but you still need iron, I mean, so it's not going to replace this stuff. But I do think that managing the symptoms and then later, hopefully getting to outcome treatments, um, this is just an easy recommendation that people can follow. I'm not telling you to completely change your whole diet, right? You just print out a list, you put it on the fridge, and you check it off during the week. This is a super simple way that my patients can get, okay, I get it, right? It's like instead of, well, man, I got 5 left on the week. Looks like we're having a big salad for dinner today, or something like that, right? Instead of going, all right, do I need the big yeah, everyone likes a prime rib or something like that, if that's what they like, or a fish. You can still have those things, right? I think taking away um, things that people enjoy is actually harmful because they enjoy those things. The other part is if your family history is from Norway, and that all those genes, all those thousands of years ate a lot of fish, and now you go totally vegan, your particular microbiome may not agree well with that particular diet, right? Or if your family grew up in the Mediterranean and you go to an all meat diet, you're probably going to have horrible gut issues for that, right? So that's why I think, establishing a base, kind of measuring what are we doing and how do you feel baseline will then help the future stuff. So the recommendation was just merely to help out instead of making what are little things, right? Walking. That's the other thing I recommend. At least go for a mile walk. If you do anything else, okay, we can go up from there. You walk a mile a day and you eat 30 different vegetables a week. You're doing more than 90% of people are doing right now, and I know that it's going to help people. So how can I get people moved in that direction? So hopefully that answers your question.
Just one more time to drive it home. If you do 30 vegetables and you walk a mile a day, did you say a mile a day?
Yeah.
If you do 30 vegetables and you walk a mile a day, and I'm going to speak to some people believe there's mineral deficiencies, and you did talk about iron, and of course we can become iron deficient, we can become B12 and folate deficient, and if we're on hormones, we may need calcium supplementation. But in general, for example, zinc. This population in the United States is not zinc deficient in general. Tell me if you agree with this statement. We're not deficient in zinc in general, but especially if we walk a mile a day and we do 30 vegetables, we do not need to do zinc supplementation. Is that correct?
Like I said, some people,
No.
it depends on your baseline.
Yeah.
Yeah, in general, maybe if you had a pretty well balanced diet beforehand, you're on the tea and toast diet for years because you have a gut issue, well, you're going to have deficiencies in stuff. And so I think this isn't an all or none thing, right? It's okay, this particular patient, I have to be concerned about certain things. We're talking about microbiome gut here, and what I responded to was, what is an easy way, what is a general recommendation I give my patients before I can get into the real specifics of a certain person? The general is that, right? That's our just baseline. Can we get that stuff going? Then we go, okay, you're micro deficient in this, you're macro deficient in this. We need to shift these things over. And this is a whole team approach, and this happens over time. This is not a one-time thing. And so, that to make blankets, I don't like to make those blanket statements because someone will prove me wrong, right? And I don't mind it, but we got to work in individual patient level rather than just saying, yeah, you're never going to need to take a vitamin if you do that. That would be a not true statement. I know it's not maybe what people wanted to hear, but I think it's an individual aspect and what is your baseline, right?
May I ask one more question, or should I turn the table over to other people?
Sure, we can ask.
Okay. The other question is, I talked to my GI doctor and I asked him what has made it to prime time in the gut biome world. And he said that fecal transplants for, I may have missed this. I came late to your lecture shoot, so you may have already covered this. So please excuse me. He told me that fecal transplants for C. difficile colitis is the only thing that has made it to prime time in not academic medical centers, in mainstream community hospital GI pathology practices. Is that correct, or have other microbiome things made it to prime time? And what I mean by made it to prime time is have been entered into practice guidelines.
Yeah. So that's correct. Only C. diff, right? And if you've ever had C. diff, you'll do anything to stop the diarrhea, right? So and that makes sense, right? Those are the extreme messed up gut, right? Can we improve that? Yes. Again, we have to be super careful with these fecal transplant things. And so Europe has done some, and all these are phase 1 and phase 2. We're seeing some signals, not have not made it in. None of the actual things that you can test right now, if you're going to get off this and try to go order a kit, that hasn't really been shown to help. We are still in the midst of studying this. That's why I gave the general recommendations, because that's probably the most, we have data to show that plant-based diets and exercise help outcomes. We know that. What are the particular bacteria that are driving these things? That's what we're trying to research and then maximize those things. So we don't have that yet. But that's what people like me are, really trying to focus and hone in on. And obviously we've hit, there's a lot of questions and we've hit on a topic, right? And I think diet, and we all say we want to have this particular diet. And then when rubber meets the road 2 weeks in, you're like, man, I can't do that. You end up going back to what you've been doing. And so I think giving small snippets of benefit. Somebody asked about the portion sizes. And to me, whatever you can get, 30 different vegetables. If it's one celery, it's one celery. If you have 3, awesome, right? I'm just trying to get you to think, okay, if I'm putting in my lunch for the day, what do I got in there? Okay, I got carrot, celery, and spinach. Sweet. Got 3 checked off already. Awesome. And I just think it's and it combines not the bacteria that are in there, but they may not survive through, but it's the micronutrients and the prebiotics, right? The food for the different bacteria that go into your gut that are helpful. And so some are asking about turkey trail mushrooms. So again, we'll all have this one-off. I had a patient say, I ate grapes for 30 days straight and my PSA went down. Okay. I don't know how I can transfer that to someone else. And maybe you were on the rung of the ladder where somehow grapes, expanded a certain type of bacteria and then you felt better and the PSA came down. But like I said, we have to test each one of these things. So mushrooms is one of the vegetable. Great. Has a lot of different vitamins in mushrooms, depending on how you cook it. Try not to use too much butter, stuff like that. But there's definitely a lot of food as medicine kind of stuff going on, research going on in that. We just have to be careful about saying this is the one thing, right? Because it may respond different in different patients. How do I measure a good gut day? I don't get to measure that. You get to measure that. And by the end of the day, if you're having bloating and diarrhea, that's a bad day, right? If you had cramps, bad day. If you had normal, if you look at a Bristol stool chart, you can see if you're constipated or not. But usually if you have a stool that's long and kind of makes a C into the gently curves into the toilet, that's a good bowel movement, right? Clumpy stuff, a lot of floating stuff, small balls are hard. We know we got to increase our water, right? So that's what I mean. We got to be measuring this over time, because you could eat something that worked amazing for somebody else. So I think one of my patients brought in like a vegan pizza once. Everybody was like having, I'm like, well, if you're not used to a vegan diet, right, you're gonna have some bloating and stuff like that. And to get you to change, you may have to go through a little uncomfort first to get to a good place. So that's what I'm saying. This is a longitudinal and directed patient-specific plan that we need to get to for patients. And so for there's one about FDA approves turkey tail trial for cancer patients. Yeah, again, trials. And this one's not in the US. Some MSKCC is looking at that. So Memorial Sloan Kettering. So again, I have looked at there's a lot of curcumin studies out there. There's a lot of different supplements. And like I said, I have a PhD, and that's what we did on drug development. How do we take natural products and move into drug development? Well, you need good manufacturing practice. They have to be held to the standards of the pharmaceuticals, and right now they are not. They just have to not contain bad stuff, essentially, and they have to be GRAS, which is generally recognized as safe. So there's like a lower bar for natural products than when we're using for therapeutics. So we just have to be careful that some of these things may or may not work for certain people. So that's where I'm coming in going, okay, let me test combinations of these things. I give it to a randomized clinical trial using good manufacturing practice, using pill design, um, measuring blood levels. Does it actually, because a lot of this stuff you take and it gets metabolized really, really quickly. And it actually doesn't even get into your bloodstream. Um, so just because, the curcumin is one of those things, it just gets glucuronidated in the liver really, really fast. And so you can never get really high levels of blood curcumin levels. You just can't do it. And so that may be the same with different mushrooms and things like that. There may be a component of it that's driving it, and more research is needed. And that's always a hated comment from patients who are going through cancer, because you kind of like want it now. That's mute. Because people want stuff now, right? We want to get things going, and what can I do to help myself that may be being overlooked. And so I think that's what a lot of the microbiome industry hasn't really focused on yet, which is what I'm kind of taking on, basically. Blanket inventory of labs for deficiencies. I work with my hemonc or oncology as a surgeon. I don't necessarily need to check a lot of those things. And most people aren't deficient in some of those, but I know, vitamin D is a pretty common one we check. We check, I've started checking folate levels, red blood cell folate, especially because it's a longer term measurement. Serum folate can be quite variable day to day and depends on the diet that you're eating. Folate in some instances are good if you're really low, and if you're really, really high, that's not good either, right? So it's kind of this bell-shaped curve where you kind of want to be in the middle with folate. And I have another talk I did, if you look that up, on folate and prostate cancer. I think it was in Grain Rounds Urology. And so, I don't do blanket testing now because I don't necessarily know of particular things that impact the outcomes, but it will matter depending on what chemotherapy or what treatment you're doing. There are certain drugs that can chelate to those particular uh, nutrients or vitamins and things like that. So you can get deficient in certain treatments. So I think that is something that we need to, cover. I know there's, again, companies out there that check all this stuff, but when you bring it to us, it's kind of like, well, okay, how do we necessarily fix that? How long are you on a vitamin to correct that for? It's kind of challenging. So that's why I say if we start with a lot of the stuff comes from vegetables. So say a lot of these small changes that may look big on a piece of paper going, oh my God, I'm deficient in X. If we just kind of increase our diet, sometimes those small variations can go to green, and then commercial tests. So yeah, this one's so commercial tests that are out there. There's a lot. So there's a lot of competition, I think. It's complicated. So some of it is just for, it's kind of like 23andMe in the early days when you can go check your ancestry. You kind of get this report that's a little bit can show your diversity. It'll give you your diversity scores and things like that. But I wouldn't necessarily endorse a particular one or not, because none have been tested necessarily in particular in the cancer space. A lot of it is for generic health and well-being. So some of the ones that are out there are Thorn. They just had and they have been focused on like athletes, dietary things. There's Viome, there's Biome, Sun Genomics, um, and my company, Uncle Biomics, but I haven't released my kit yet only because I'm really focused on this particular cancer patient journey, not only forming biomarkers for prevention, right? Because we know that diet and lifestyle choices are about 30 to 40% of cancers. Okay, so why is no one working on that? Well, we did a bunch of prevention trials. We spent a lot of money and they didn't work. I said, well, we did it on a population level. We didn't look at individual patients who are more likely to get cancer. So can we combine genetics and maybe microbiome and lifestyle changes together to do prevention studies? So that's one arm. The other arm is to do this pre-post testing and kind of these different during or before treatment, preferably, kind of like what Rob was alluding to. Can we do assessment beforehand or at the time of problem, offer, and I think that offering, companies that kind of say, well, hey, we happen to also sell this probiotic and this thing. We have to just, well, is it really tested to prove to increase that or not? So I kind of like it when they give you, well, these are things that could increase these types of bacteria, and then let you kind of go search for things that may impact that, right? Because maybe you can't afford the monthly probiotic that they want to send you, and you don't really know if it's going to work or not. And then the last part is the kind of the daily management or log, if you will, of managing over time to see, okay, hey, I changed something, but it doesn't look like it's working. I need to pivot, maybe retest, and then try something new. So there is stuff out there. How useful it is. There's been a lot of complaints on the reports that are generated that are like, well, they're a little confusing to understand and what exactly am I supposed to do here with this information? So I'm always a little hesitant to recommend particular companies because I haven't seen that quite solved yet.
Dr. Liss, we're past the hour, so we should probably wrap up. Do you have any closing thoughts you'd like to share with us? Any summary?
No, I think that this is a new aspect. Hopefully, I gave you a little bit of gestalt on what's coming and how the microbes can interact with our immune system and how we can manipulate it with our diet and things like that are coming. It's always a sensitive topic in that we have to be careful, especially with our patients that are in the cancer journey, because it's a vulnerable time and we're looking for stuff. So I want to make sure that, I'm an advocate for you when we're looking at the microbiome and making sure we're not overselling something, right? Because this is a vulnerable spot. We need to make sure we're making good recommendations and doing good research to make sure that you guys are benefiting. So thank you very much for asking, and I don't know if you have my email. You're happy to share that. I can